morning, everyone. My name is Yoong. I'm a moderator for the second session. Thank you for joining us for the live webinar. We are very honored this morning to have Prof. Davina Porock from Edith Cowan University, Australia. Okay, so a little bit about Prof. Davina. She's a director of Center for Research in Aged Care, and she holds a VC professorial research fellowship in the School of Nursing and Midwifery. And her research program focuses mainly on living and dying well in a residential aged care. And one of the research work that in progress at the moment is focused on end-of-life care. And according to her, in Australia, most of the people die in a hospital or the aged care, even though home is preferred. And often because of that, the clinical deterioration is not recognized and there are no advanced care plan in place. And because of that, this morning, she would like to share with us about advanced care planning, preparing for end-of-life care at home. So without further ado, okay, Prof. Davina, the platform is yours. Thank you.
Thank you and good morning, everyone. And thank you so much for inviting me. I've had a long association with University of Malaya School of Nursing, and I'm very pleased to be back. I've actually been tested positive for COVID, so it's lucky we were online, but I'm absolutely fine. The other little thing that's happened, just at the end of the previous talk, my power went off. So I'm now on the battery of my computer and hotspotting from my phone. So if I disappear, it is just because my phone's run out of battery, but it looks pretty good at the moment. So let's get started. I'm going to share my screen. And I have just slightly changed my title, and I'm going to call it Comprehensive Advanced Care Planning, because there's more to it than just the formal part, which you're probably all very familiar with, which is the documentation and health directives. So that's me. You've heard about me already. And basically, this is what I'm going to talk about: the Australian context of dying and a brief history, because 150 years ago, everybody died at home pretty much. So we're trying to do full circle here. Currently, what's issues in palliative care in Australia and where we are not meeting expectations. And then we'll get into the bringing dying back home and the planning and everything. And I'm hoping, if we have got time, to talk about this and get some cultural feedback, because I realize things are different. So in Australia, we have almost 26 million people. And fortunately for us, most of the people who die are old. In fact, the biggest proportion of deaths is in over 75. So there's 4.2 million people who are over 65 and over. It's only 16% of our population. And I'm not sure about why we still have 65 as old. I'm getting very close to that number, and I don't particularly feel like it's retirement age. And in fact, you don't get a state pension in Australia until 66 and soon to be 67. Why we stick to 65 as a definition of old, I've no idea. If you want to talk about old, I think Australia has 2% of its population at 85 years of age or older, and there's just over 500,000 of those people. And that's a significant age, because the average age of people entering residential aged care is in the mid-80s. So it is starts to be clearly when people have specific issues. Contrary to popular opinion, only 191,000 people live in residential aged care. I know that there is a belief in the world that in Western societies, we just stick all our old people in residential aged care and rather than look after them by the family. But that actually is not the case. As you can see, if you count the old people over 65, less than 5% of them are in aged care. And only just over a third of them, if they're over the age of 85, are in residential aged care, which means that 2/3 of over 85-year-olds are being cared for at home by their families and services, of course. But that also means that with its a relatively small and dropping number of people, it's fewer people proportionately are entering residential aged care, and the ones that do are very high care, very acute, 24/7. Often the majority have dementia and with behavioral issues which are very difficult to manage for the family on a 24/7 basis. So residential aged care in Australia is rapidly becoming a very specialised subset of geriatric care, and I think that and home care and support at home by services is rapidly increasing exponentially, and I think that will continue. They've already crossed over. There are more people receiving their aged care in their own home than in residential aged care now in Australia. So where do they die? As suggested in the introduction, just over half of all deaths occur in hospital. Almost 30% die in residential aged care. It's actually just less than 15% of all deaths occur at home. And then we have, in the Australian Bureau of Statistics, we have 1.5% occurring in some place called other, and another 3.5% of deaths in an unspecified location. What the difference between those two is, I haven't unpicked. And somewhere in there is hospice, because most people say in the research, around about 70% currently of people want to die at home, and if you ask them for their second choice, it's hospice, but it's very unlikely if you're old and frail that you will die in a hospice. So in 2021, which was a COVID year, 172,000 people, it's just less than that, died in Australia, and 2/3 of those were over 75. As I say, fortunately in Australia, most of the people who die are old, which means that they have been successful humans and lived to a good old age. As I said, 70% of Australians state they would prefer to die at home, but only actually the exact figure is only 14.8% do. And unfortunately, that includes suicides and accidental deaths, not just those that are planned to be at home. So the number of people with planned who know that they're dying, want to die at home, a very small proportion of them actually get to do that. So I thought we'd go back in history a little while and do a sort of a Western version of dying. It's not a full history, obviously, because people have died ever since we existed. So I've gone back to Queen Victoria, and let's look at how death was then, 150 odd years ago. So mortality rates were high, life expectancy was low, and most people died at home. Another frequent place of death in those days was, of course, the battlefield. So dying was very much considered a religious and spiritual journey or process. And it was considered to be a moral trial in preparation for Judgment Day. The Victorian poets and authors were very much romanticized, and I think many of you will be aware of Gothic literature, and so the dying process and death was very much romanticized in fiction and poetry. I've put a picture in there that children were encouraged to witness deathbeds and become familiar with dying rituals. And I know my mother, who is now 90, almost 91, when her father died at the age of 10, so that was in the 1940s, she was actually withheld from the deathbed. She wasn't allowed to see her father. So from Victorian age to somewhere in the middle of the 20th century, that had changed. This is all the pre-anesthetic era. And so when we talk about hope, in those days, it was hope of the prospect of heaven and eternal life, not in restoration of health or the hope for elimination of pain, which is the language which we use these days for hope. So the ultimate model of dying, and dying well, was Christ's death. So people looked to that experience of dying with patience, humility, despite what agonies were enforced upon him, and how you faced pain during dying was a sign of how godly you were or ungodly you were. So there was a lot of pressure on the dying person and on the family to behave in an appropriate way. So I think you see where I'm going with this, that things have changed a lot. In terms of caring for people who are dying, back 150 odd years ago. It was very much part of household management, not the professional province at all. So Mrs. Beeton was a famous author. She wrote Mrs. Beeton's Book of Household Management. She also wrote cookery books and things like that. But in teaching women how to manage their household, and clearly these are fairly well-to-do women, but it did say that all women are likely to, at some period in their lives, to be called to perform on the duties of a sick nurse and should prepare themselves as much as possible. Now, a nurse in those days was someone that you gave your baby to breastfeed in your absence. So a sick nurse was a woman who was extended the duties there to looking after the sick and the dying. And what they required of people looking after the dying in those days was compassion for suffering, sympathy, neat-handedness. I'm not sure why we needed that, but anyway, quiet manners, love of order and cleanliness. And I think the next part is really interesting because there's a recognition of how awful death can be, and certainly death without any palliative pain relief and symptom management in those days, that this kind of desire to relieve suffering that inspired 1,000 attentions and surmounts the disgusts which some of the officers, which is another word for functions, attending the sick room are apt to create. So they recognise it was not a pleasant experience, but the person of the nurse and the woman of the household would be there to provide compassion and support. So what did people do, given that you couldn't give them pain relief and etc., manage their dyspnea? So they spent time in conversation, prayer, reading from scripture, and keeping vigil. And in many ways, those things are still part of the palliative care process, but they're not the only thing that happens. So when did palliative, as we know it, really begin? Well, it began, it wasn't called this, but once we had the introduction of anaesthetics in the late 19th century, we began to see the arguments that we should be working to support and reduce the pain and suffering that dying people were experiencing. Physicians of the time, their focus and their profession was on diagnosis and treatment, as it is now. And they had to be persuaded through the literature of the time to include relief of pain and suffering into their scope of practice. So it's been a transition in medicine of including the care of the dying into medical practice. And of course, those parallel things have been happening in nursing as well. So we know we've got the middle of the 20th century, we've got the first modern hospice with Dame Cicely Saunders, who started that. Her aim was to demedicalise dying. And although I think that was somewhat successful then, we certainly know that dying has become remedicalised, and we're still trying to demedicalise it and normalise it now, but in a different way. So the focus has always been on cancer. Cancer was the big condition that people were feared dying from. It was the one with the most pain. And the criticisms of this focus came in the later 20th century, where it was called a Rolls-Royce service for a few, because as people and as medicine was able to manage cancer, the shift of what people died of changed, and now people die of heart disease, cardiovascular conditions, and in fact in Australia the second highest death cause of death is now dementia, at least for women. So the Rolls-Royce service for a few, and as that quote continues, the jalopy for the rest. So we're trying to shift that away from cancer to include everybody. By the time we get to a bit later in the 20th century, palliative medicine was actually a formal medical specialty. So you think we're doing pretty well, things are changing. Australia is classified as having a world-class palliative care, but I'm sorry to say that still not all dying people have access to palliative care. Some medical but they're still very reluctant to refer to palliative care. But our biggest areas of problem are rural and remote areas, where and we have a very big migrant population, multicultural communities, but people from cultural and linguistically diverse communities, as we cutely call them, COLD, also have limited access, often due to communication and just they don't know about it. Older adults, which is crazy since most people die when they're old, those who are actually in and receiving aged care, those with disabilities, people with dementia, mental health, if you're in prison or if you're homeless. So our marginalized communities, as we call them, are having a lot of trouble accessing. So despite our world-class services in palliative care, at least half of the deaths occur in hospital. Here's a study from a few years ago now that asked relatives of those who've died in hospital about the quality of care and what needed improving. So as you can see, pain, dyspnea and anxiety ranked very highly as being still a problem. They were saying that their relative who was dying suffered from these things extensively. However, they did feel that they were treated kindly and were given assistance. And it seems amazing. And overall in this study by Carey, people were very pleased and happy with the care that they received. And it's sort of mind-blowing to someone who knows that what palliative care can do, that you can be satisfied with 73% of people being in pain at the end of life. So where people wanted improvement was support for family and communication. And this receiving contradictory and confusing information was also a big issue. A little while ago, it's some time since I looked at the statistics, but in the UK, 50% of all the complaints that went to the Commission were about communication problems at the end of life. So people say they want to die at home, they end up still dying in hospital or in residential aged care. So why doesn't it happen? Why are we not able to provide the palliative care that we can now do at home where people say they want to be? So our society has changed a lot. And if you ask people, they say, look, it's just not realistic. We need to work. We have the children to look after. There's only a small family now. It's hardly anyone to help. And of course, the big issue for many, many countries in both sides of the migration equation, people live in a different, geographically spread. So people have sent their children to Australia, United States, wherever, to get an education and a so-called better life. And then, of course, the older people are left there, and there's all of these issues. And people are working in the country they've migrated to, can't get back, and it causes all sorts of issues and guilt and disruption. And the other thing is that we have much smaller families, so the division of labour in caring for someone who's dying, and dying does take a long time these days because of our medical advances. So we have difficulty pulling together a community of family and friends to provide the 24-hour care. And I'm sure in Malaysia, just as it is in Australia, there's a shortage of people who are available to provide home care as paid positions. We've had these medical advances, so it means people are very much older with multiple conditions. And so the requirements for nursing care is much more sophisticated. So the way families used to be able to provide care and what is required of them now, and the complexities of care, medications, etc., is another issue that makes it very difficult for people to die at home. So making death salient, we think that, well, of course death is salient, death is extremely relevant, but actually we don't talk about it. And it doesn't matter which country or culture you come from, death is one of the taboo subjects, and it certainly is in the Western culture as well. And I think, in my experience, people can be very sensible and reasonable about talking about death and planning if they come up against it. But in Western societies, people with older people really only come up against making decisions about dying and death when they are in a crisis situation, when they have got to the point where, they've come into hospital with community-acquired pneumonia, they come in for IV antibiotics, they're not getting better, and they get to the point, do we send them to ICU, or do we wait and see if they're actually get better or transitioning to dying? When people are at home and receiving a lot more aged care at home, these crises don't happen in the same way. You don't, unless there is a big crisis and you've already in hospital, people are not having those conversations. So we're trying to make death salient to them so that they will have those sensible conversations. So if you're going to bring dying back to home, it's all about planning, because life is very complicated. There are not people at home all of the time, because everybody's out at work and doing things, very, very busy lives. So if you're going to plan something, just if you're going to plan a holiday, you want to know, when is it going to happen? What will be happening? What do I have to do? What happens if something goes wrong and I can't cope? And who's going to help me? So this is all about planning. As we get to this work in progress that we are in planning, quite a comprehensive process. I'm drawing on all sorts of research that I've done over the years and the research of my colleagues at Edith Cowan University. I'm going to send you to this site, eprognosis.org, and I particularly like it if you go on and look at the bubble view. What you see here as prognostic calculators that have been developed using research for many different situations. If you see just up here, I hope you can see my cursor, this one here is mine. It was, I don't call it the Porock, I call it the MMRI, but it was designed using data from the minimum data set when I was working in the United States. And it used 43,000 people to develop a prognostic calculator to estimate the likelihood that a resident come up with a score which says that you know 10% of people with a score like yours died in the next 6 months, or 90% or 75% of people with that score died in the next 6 months. And it makes the idea of salience, so that it becomes very relevant to you if you can see that your older person or you yourself has a likelihood of dying. I'm not going to go into the details of that. If you'd like, I can give you the papers on that. If you wish me, I can email them. But go onto this site and because there's a variety of calculators to help us to actually know when dying is happening. It's not such a mystery that we think. So the solution to planning, of course, is advanced care planning. Mostly when you ask people about planning for end of life, they may think about advanced care planning, advanced directives, etc. They'll go straight to what they want at their funeral or writing a will. And of course, that is not actually planning for the dying, that's planning for the death. And so getting people to actually do the hard part, which is planning for the dying process and how that's going to be, is what this research and what our basic aim is all about. And I have to make a comment about advanced care planning. When you think about it, you would think if you look at the National Plan for Palliative Care in Australia, you would think that advanced care planning was going to fix everything. But actually, what it does is helps the medical staff and the medical team make decisions about what to do. It doesn't actually help plan for where and what and who are going to be there at the dying process and the end of the person's life. So advanced care planning is at the core of our work, but it isn't enough, which is why I've started calling this comprehensive advanced care planning. So how do we go about getting comprehensive advanced care planning? So we need to demystify dying. We've taken people away from the bedside of the dying. We've professionalized it. So a lot of people now are very frightened of the dying process, thinking it's a mystery, that it's not knowable and it's out of control. And in fact, that is not the case. I teach the physiology of dying process, where you can actually work out, instead of saying, well, as something deteriorates, we want to work to stop it from happening, but you just use that process of multiple organ failure to understand what the symptoms are that will be coming and how to anticipate the next stage. And we need to reskill families. So at a societal level in Australia, we're trying to do this at a number of levels. We're breaking the taboo with something called death cafes. I'm very happy to talk about that another time. Dying to Know is another a group who provide information sessions on death and dying, about hospice and palliative care, but also include what is now a legal option in Australia, voluntary assisted dying. And then another social movement is compassionate communities, where particularly in rural areas, people are getting together. Their children have left to go to the cities, and they're getting together to support so they don't have to leave their towns and farms and whatever in order to receive care. So what are we doing in our interventions? So we've got this societal movement towards supporting dying at home. So we have developed, are developing our intervention at the moment. We have a vision of what that looks like, but what we also need is we want it to be really relevant for the people who are going to be using it. And the people who are going to be using it are the people who are dying at home. In our home care services, we call them clients, and and the families who are supporting them. So families and friends, their personal network of people. So our first step is to, and these are the studies we're actually doing at the moment, and I'm sorry I don't have data to provide for you. We're asking family members and home care clients, what do they need to know? And we know some of the things that they need to know already, but we don't know everything because we're in process. When we've done those, we're going to talk to the personal care workers. So these are not nurses or registered nurses or enrolled nurses. These are people who have who provide the personal care in an unqualified but very loving way to people at home. So what do the information and support needs of these people to support dying at home? From there, we're going to work on focus groups to work together to develop the process and a workbook. We've obviously drawn a lot on the literature and the research expertise in the team that works together. So how are we translating this research into practice? So the first thing, I'm going back to that tool that I mentioned before that I developed for residential aged care to predict likelihood of dying in the next 6 months. I'm very fortunate that people have picked up on this idea and have used it independently in a number of settings. There's 2 papers which have been surgeons that have used the predictive model to help people make decisions about whether they would have orthopedic surgery or tracheostomies or start particular medication. We've also had people using it to predict the likelihood of dying, so that before people leave hospital, that they would ensure they have a palliative care consult before they leave the hospital for older people. So it's been used in a number of ways. It has also been used in the community, and it was found to be pretty much on a par with community nurses in the UK, and whether they thought someone was likely to die. But having the number, the percentage likelihood of dying supported the nurses in talking to the general practitioner about starting to the planning and also talking to the families. So we're going to validate the tool in the Australian home care context. And what we want to do is embed it in the administrative and clinical data that's collected regularly in practice. And then the IT systems will report and flag if someone has a greater than 50% likelihood of dying in the next 6 months. The care coordinators are being trained to initiate the conversation with clients and asking if they would like to go on this planning process. I have to say that in the home care service that we're using, they'd recently done, or last year done a what the highest priority that they came up with, they need more information on end-of-life care. So the next step, having been flagged, and then the care coordinators initiating a conversation about would they like to discuss. I mean, they might call on the registered nurse or the GP to do that conversation. But if the family then chooses that they want to go on the planning process, this is what we're suggesting. Again, this will be developed further with the focus groups of families and clients from home care, and drawing on GPs' palliative care expertise as well. But from the research expertise that we have at Edith Cowan in the Centre for Research in Aged Care, we've suggested that we have these are the topics that we will probably do. I will be doing the introduction to the dying process. So we're actually going to, in lay terms, talk about how the body shuts down and how we can anticipate symptoms and hopefully demystifying that process. And I'll talk about what palliative care is and what it offers. We will talk about advanced care planning and that formal, and the importance of that formal planning. We thought some of the issues that in the literature that are very clear about what's a problem for people is negotiating care within family members when somebody does everything and everybody else just sits back and criticizes. And so how do we negotiate? How do we help people negotiate an equal load of care? Because I think it's gone away from 150 years ago when it was the women of the family. In modern times in Australia, it's everybody's job to care. Supporting the family caregiving, and what grief is like and how that feels, and how to support each other. Balancing dignity and risk is a whole area. One of my colleagues that focuses on this, I'm sure would love to talk to you about this, where we actually limit people's desire to do what they choose because we're so concerned about safety. And in this case, it's about the desire to hospitalize. We panic and send them to hospital, and then they die there or in the ambulance on the way. And then when we've done all of those things, one of my colleagues in psychology is very clear on about helping people to look at making the most of memories and making most of their time. And she calls it making memories, savoring memories. So in other words, making the most of what we have with that. So we're doing that in videos because it reduces the stress on people to read and things like that. So we thought we'd go with the modern way. Then we will offer them, so that information will be available to everybody. And then but they can also opt for having facilitated family meetings. The first one with a specialist palliative care nurse to draft the plan for dying and document the formal advanced care plannings. They can stop at that, or they can go on to meetings with a social worker to facilitate family care planning. We want this to be documented in a book, which we'll digitize, just literally, turn it into, scan it and provide it at this point to the GP, palliative care, home care, so everybody knows what that family's plan is. But in the future, we'd like to make it an interactive app because we're all very terribly modern. I've raced through it because I know time is of essence here, but I really thank you for your attention. I'll stop sharing. And hopefully we have the opportunity for a conversation. Thank you for listening.
Okay. Right. Thank you, Prof. Davina, for your informative talk. All right. I think due to time factor, we don't entertain any question, but you can always email. If you've got a question, you can email Prof. Davina, right? And I think
yes,
some Prof. Tengku Sarah from this, she putting some chats, some talk here. Yeah, we do have a hospice care in Malaysia. We're giving assist the dying patient to die comfortable at home. And also, yes. I think very good. I think she's interested in your prognostication, your prognosis, because she said she had a 96 years old parents.
Yes.
Her today. Yeah, I think she's interested in that. Yeah.
Professor, I will send, if I email the papers to you for a start, and then you can distribute them. Yeah.
Right. Okay. So you got any question, you can email to Prof. Davina. All right. Okay. Yes. So thank you very much for your attention. We'll see you.
Thank you.
Okay. Bye.
Thank you for inviting me. It's lovely. Bye-bye.
Bye-bye.